Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the DentaQuest Foundation, on building community partnerships to address social determinants of oral health. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a question and answer session following today's presentations. You may submit a question online anytime by clicking the chat icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you'll take a moment to do this. I will now turn the webinar over to June Glover, Program Officer at the Center for Healthcare Strategies.
Thanks, Travis, for getting us started here. Hi, everyone, and thank you for joining us today. We're going to jump right into the agenda and quickly go through the topics for today's discussion, starting by welcoming you all again to our webinar and introducing our guest speakers. We'll talk a little bit about our work at the Center for Healthcare Strategies and specifically within the oral health space before moving into the framework to build partnerships around social determinants of oral health. We'll then turn it over to our guest speakers for the perspectives from the field, and following that, open it up for some questions and answers. Without any further ado, I'd like to introduce today's speakers. Again, my name is June. I'm a program officer here at the Center for Healthcare Strategies, serving the child health quality and complex population teams. I'll be presenting today and facilitating today's webinar. I'm pleased to introduce our two guest speakers, Parrish Ravelli and Bill Dennison, who we are thrilled to have on to share with you their insights into building community partnerships. Parrish is the team lead for the Access to Healthcare Initiative at Youth Empowered Solutions, a nonprofit organization that empowers youth in partnership with adults to create community change. Since 2006, Parrish has been working in the field of youth empowerment in a variety of settings, including tobacco use prevention, municipalities and youth councils, and most recently, healthcare. Bill is the Director of Major Markets at the United Way of Central Jersey, where he has spent over 10 years developing resources and collaborations to support community initiatives. Here's a little bit about the Center for Healthcare Strategies. We are a nonprofit policy center dedicated to improving the health of low-income Americans. Our priority areas cover the three topics in color here: integrating services for people with complex needs, enhancing access to coverage and services, and advancing delivery system and payment reform. We aim to impact these areas through providing technical assistance and promoting best practice dissemination, collaborative learning, as well as leadership and capacity building. The Center's portfolio of initiatives to advance oral health care coverage, access, and quality for children and adults served by Medicaid dates back to the early 2000s. It includes technical assistance for both individual states and collaboratives of states, leadership on regional and national advisory teams, and also data analysis. Our work has spanned across the country, always with an emphasis, again, on advancing collaborative learning and dissemination of best and promising practices, as I mentioned earlier. We have been fortunate to have these efforts generously supported by various foundations, as well as the Centers for Medicare and Medicaid Services. So that was a quick overview of our work here, and now we'll proceed to the discussion of a framework to build community partnerships. We'll begin with a definition of social determinants of health. According to the World Health Organization, social determinants are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped largely by the distribution of money, power, and resources at global, national, and local levels, and accordingly include things like economic policies and systems, social norms, social policies, and political systems. Here's a look at how social determinants and oral health are interrelated. This is one feedback pathway from a model created by dental faculty at the University of Toronto, which depicts how poor socioeconomic status at the top there produces psychosocial stress that influences certain risky health behaviors that then lead to susceptibility to dental disease that impacts dental appearance and subsequent employability. This is just one of several ways that social determinants can influence oral health outcomes. Community assessments are essential to understanding social determinants that influence the health of a community. They help to expose the gaps created by social determinants and highlight these opportunities for intervention. In conducting these assessments, it's important to first consider the types of information needed to pinpoint the issues. Examples include data on morbidity and mortality, like emergency room visits and prevalence of dental caries, data on risky behaviors like smoking or poor diet, and data on socioeconomic factors like education and transportation. Using publicly available data collected by the CDC or your local health department and academia is helpful, particularly when paying attention to any disparities between findings in one community compared to state or national data. These will begin to tell the story about the community and its determinants, but not all data are perfect. Some are outdated or incomplete, which makes the case for collecting additional information from the community through surveys, focus groups, and so forth. Once the social determinants facing a community start to come into focus from looking at these data, mapping the community resources helps to reveal its capacity to change social determinants. Often we think of just other organizations, but it's helpful to think beyond that scope. Community capacity actually refers to resources, infrastructures, relationships, and operations. So some examples include, as listed on the slide, human capital, like skills and professional experiences, social capital, like established relationships and networks, cultural capital, traditions and preferred language in a community, political capital, like civic engagement, and built capital, like schools, hospitals, and businesses. Of the existing capacity within the community, you need to determine what's most helpful to address social determinants. There are likely networks to leverage to get people involved and spread information about social determinants, to gauge their interest and build will. For example, you can think about local professional organizations, schools, businesses, faith-based organizations, etc. Areas where you can interact with community members and encourage broad community participation. Lead with open communication through regular conversations and meetings to build the relationships that will lead to partnerships. Once that groundwork is underway, to understand inequalities and a community capacity to address them, you can begin conversations to plan the partnership, starting by defining a clear mission and vision. A clear mission and vision are helpful in ensuring that the partnership stays laser-focused. The benefit of broad community engagement, which I mentioned earlier, is the potential for enhanced impact, but prioritizing diverse interests can be challenging. So working from the list of determinants and resources should help the partnership stay on course. Building on existing values from well-respected organizations in the community, by tacking on specific actions to address social determinants is also helpful, and working towards a consensus-driven statement that describes the change or partnership and visions in the community is another way to start putting together that mission and vision. Working to achieve this mission will take a strategic approach where the partnership identifies specific activities that align with the mission, sets goals and objectives to drive success, and considers the timing of activities to build on momentum. Here are 6 useful approaches to addressing social determinants from the CDC resource on promoting health equity. Each approach has a different accomplishment, which we will quickly go over now, along with some examples of activities that would fall into that category. Going down the list, 1, conscience raising. Encourages critical reflection within individuals. The aim here is to humanize or personalize an issue to make it more relatable. Examples include testimonials and photo voice. 2, community development. This empowers community members to have more influence in their communities to reverse feelings of hopelessness or powerlessness. People are more inclined to participate when they believe they can have an impact. Examples include voter registration and neighborhood cleanup. Social action. This highlights the impact of social factors like physical environment and food access on health. Examples include symbolic activities and public demonstrations. Health promotion. This is a classic public health intervention that aims to motivate people to change their behaviors and attitudes toward health. Examples include policies to improve food access and physical environment. 5, media coverage. This influences societal perception of an issue and generates public attention. Examples include traditional media placements in TV and radio, as well as social marketing through outlets like Facebook or Instagram and Snapchat, which are particularly important for younger audiences. And last but certainly not least, policy and environmental change, which impacts the decision-making process. And you can think of city council meetings and policy development. As with all things, there are benefits and drawbacks, which should be considered before selecting an intervention. While these approaches are designed to improve equity, they also run the risk of potential drawbacks like misrepresenting the community or offending conflicting perspectives. Tapping into the community for feedback early and often is a good way to mitigate those drawbacks. Next, we can talk about how to establish goals and objectives. There are varying opinions about when to establish goals and metrics for evaluating the success of an intervention. But here we suggest developing the goals for a given approach at the outset, keeping in mind that these goals should also tie into the mission and vision of the partnership and be regularly revisited to see if they need to be tweaked. The goals are the long-term accomplishments that can focus on all social determinants of a community, which is very ambitious, or zero in on social determinants that affect a specific disparity. The data from the assessments about disparate populations and their magnitude should help to drive development of these goals. The objectives are time-limited or short-term activities to achieve the goals and should reflect feasibility considering the community capacity and target determinants. One approach to setting objectives is to consider the desired impact on individuals, organizations, and the community as a whole that are needed to achieve the goal. These goals and objectives should be tracked through meaningful measures with some considerations for availability of data and the need to collect new data. Establishing milestones are key to signaling incremental progress that can be a motivational factor for a sustained partnership. Share this progress with the community and let them know that their feedback has been put to use. Some ways that folks have gotten out the word are through scorecards, progress reports, and meeting announcements. So in closing, building a community partnership can be summarized into 4 parts. 1, community assessments to identify the issues. 2, community mapping to identify resources. 3, mobilization to build relationships and establish shared values. And 4, evaluation to determine impact and identify additional areas for improvement. Okay, so I'm going to pause there so we can stop and take a few questions that have come through on the Q&A. So we have a question related to the slide on goals and objectives, and this also came up throughout the course of our learning collaborative on how to set goals and objectives with competing priorities. So the specific question is, how does one communicate to partners who have differences of opinion around goals and objectives? And what we have talked about in our learning collaborative and more broadly is using the goals and objectives as a way to understand what's important across the board and using the data as a guideline for what exactly is most pressing in the community and trying to stick to that. So using the data to guide conversations on where the most disparate conditions lie, as well as using the community capacity to inform where the partnership can actually work, are useful in trying to resolve any conflicting goals, objectives, conversations. So I think we can move on. So Parrish, are you on the line?
I sure am. Can you hear me?
Yes, welcome. We're going to switch it over to you.
Thank you. I also just wonder, a quick note, I might also say additionally to that question about conflicting agendas, in my experience, I have seen value in potentially proactively and before you get to the part where you are settling on priorities and a vision, developing a framework for how decisions are going to be made can be a useful experience so that you can have collaborative agreement for the process so that when discord comes up, which so often it naturally does, there is an agreed upon process that everybody has contributed to designing so that when you are in this situation, you know, you have designed it when you are not in the situation so that when you're in a situation, you have an objective kind of roadmap to walk you through those processes. So, but I'm going to dive in. Absolutely want to say thanks to June and everybody at CHCS. This was an awesome opportunity to be a part of the Learning Collaborative. I'm going to give a quick introduction of our organization because I think it'll help highlight why this was so great for us, and then I'll run through our process, some of the things we learned, and how we will be moving forward with this information. This is just a quick shot of our Youth Empowered Solutions team at our last retreat. Yes, we empower youth in partnership with adults to create community change. One important component that I want to point out is that roughly 2/3 of our staff are high school aged youth. This is a very fundamental and core part of how we believe equity should operate within our organization, and it certainly makes for a really great time in the office. At Yes, we empower youth in a couple of ways. First, we do a ton of direct advocacy ourselves within our local communities and in partnership with our youth teams. This is a big part of how we learn how to walk the walk within our community work. Then we also help to build the capacity of our partners to comprehensively engage youth in creating community change to fulfill their missions. We do this through training adults to be able to apply our Yes Youth Empowerment model, and our youth staff train youth to be able to do advocacy and systems change work in their communities around issues that they find a priority. We really like this quote by Mark Zimmerman, who defines empowerment theory. Says, empowerment theory connects individual well-being with the larger social and political environment, suggests that people need opportunities to become active in community decision-making in order to improve their lives, organizations, and communities. And so you start to see how our work in the work of a youth empowerment framework aligns with social determinants in that it seeks to create change in this larger social political environment. At our organization, we are purposeful in saying that we do not focus on individual behavior change. We intentionally dig a little bit deeper and set our destinations on root causes and social determinants of health that we believe will impact the larger population of people. Real quick, this is an image of our youth empowerment model. It is built on 3 core components that we believe must exist at all times. So, at all times when you're partnering with youth and ultimately partnering with community members, you are working to integrate a degree of skill development, creating a deeper critical awareness, and partnering, truly partnering on opportunities to create policy and systemic change, and that these 3 components are not sequential. They happen at all aspects of the work, and sometimes with a fair amount of overlap. And when we work to build the capacity of youth to understand social determinants, we use a variety of activities, one which we call Roots and Leaves. This is not an activity we created at Yes, but we have written up the instructions for anyone who is interested in using it. Essentially, we take the problem, we write it in the trunk of a tree. Many times we'll use a whiteboard or a big flip chart paper. Then we'll ask the question, what happens as a result of this problem? In this case, on the slide, we're talking about childhood obesity, so we would write the answers to the question, what happens as a result of childhood obesity, and we'd write all the answers in the leaves. So we think rates of diabetes and heart disease, decrease in physical activity, there are correlations in academic success, and so on. These are the answers that would fill out the top of the tree. And once we have a good amount of answers, we then ask the question, but what causes childhood obesity? And we start to examine and dig in at the social determinants or root causes. This helps us think through whether and how we are actually working to address the symptoms of a problem versus its root causes. And at YES, and within the work of the Learning Collaborative, we tend to define social determinants as either policies, systems, and environments. We do this because it helps us maintain a focus on changeable solutions. In this work, it can be really easy to get swept up in the momentum behind solving massive, ambiguous problems like greed or racism. And this helps us keep an eye on targets and frame up our action plans accordingly so that we know we are having an impactful outcome. And real quick, if we look at the roots and leaves tree in the context of lack of access to oral health care, this is not exhaustive by any means, but what our youth staff have worked to put together. But you can start to delineate between work that approaches the individuals involved and seeks to influence behavior in the work that addresses the social determinants. And you can start to differentiate between the type of work that goes into each. We can zoom out even a little bit more and talk about how other corollary systems intersect to become social determinants of oral health, like access to food and water, tobacco policies, and community transportation issues. And this starts to show just how these social justice trees can overlap, because you can additionally build a tree that addresses each of these other scenarios, showing how so many of these problems are intersectional. And just as a heads up and maybe a shameful plug, we are working to develop what we're calling, it's essentially a community assessment tool. We're calling the Social Determinants of Oral Health Environmental Scan. It's something for primarily groups of youth and adults to collaborate on, to collect local community-based information that can help inform whatever type of advocacy or systems change efforts that they are going to engage in. And additionally, being a part of this collaborative has really helped to inform the development of that tool. And so we entered into this learning collaborative, and first and very fundamental part was to better understand what the data says in relation to social determinants in our community. And as I'm sure it's true for most communities, it can be just as important to know what the data does tell you as what the data does not tell you. As June said earlier, data is essential, but also comes with a fair amount of limitations. So in our county, we have very positive indicators in health and socioeconomic status and educational outcomes. However, when we were able to use the Community Commons tool, which was really fantastic, it's not hard to see and define the city within the city. And so with a magnifying glass, we're able to see that while not all the data was available at a zip code level, some of it was, and we're able to hypothesize enough about the missing data and at least develop an informed opinion about what the problems and inequities are in our community. And the truth is, the community that we're looking at is a high resource community, is the capital community of our state. There are over 500 dentists in the entire county, second only to one other county in our state. But when you put that magnifying glass on the information related to access, you can see some pretty distinct discrepancies, particularly around race and income. The next step in the process was to start to understand the layout of the community and dig in and engage partners in this conversation around disparities and social determinants. Through this process, we're able to work with partners and understand that there are really 5 key pillars that members of the community believe would substantially decrease inequities: the capacity to navigate the healthcare marketplace, a better comprehension of the school system, deeper engagement, even integration into these systems around them, bringing care to people rather than expecting them to get to it, and a very honest and humbling request for fresh and healthy food. Knowing this and knowing the data we collected, we built a plan to first gather firsthand stories that would supplement what information we had, and through doing so, we also would be able to increase the systems literacy within the community through the process itself, influence the expansion of resources, and for me, most importantly, we were able to establish a really great deal of trust. Core to this was wrapping everything we were doing in language justice so that every conversation or communication was as accessible as possible, which ensures that the partners will be present, which are green on the right-hand side of the screen in the arrow, to help address some of those gaps that are in red on the right-hand side. And additionally, I'd say through this process, an additional side outcome was that we did see a great deal of consciousness raising in our community as well as ourselves. Through these collaborative conversations that were built on the combination of data and the direct engagement of these community members, the solution was designed, which was to establish a school-based health center in the section of the community that attributed the least amount of access. This grew and is growing into a partnership between the school system and the local FQHC, the Federally Qualified Health Center, both of which are deeply rooted in the community and have so much stake in this conversation. We developed a model, brokered a plan for who is going to provide what in order to move forward, and started to broker agreements and MOUs to solidify this opportunity. So as we started to wrap up the Learning Collaborative within our experience, we spent some time thinking through where we will head with this process. And knowing that there is still work to be done, we needed to set some targets by which we can measure our success moving forward. We know that we want to drastically increase the access that low-income students have in the community and ensure that they are all accessing well-child visits, as well as dental screenings. Beyond that, we want to look into year 2. We want to start to think about how we can expand the scope of services available to this student body, to the young people in the community, to ensure that we are supporting the whole individual. And critical to this and critical to our success is the recognition that we need to ensure that our organization, that our coalition of organizational and community partners are continuing to be meaningfully engaged, and that our processes are accessible in meeting the needs of the stakeholder population, that the productive work is continuing to get done. So to wrap up my part, I just wanted to highlight 4 takeaways that I had through this process that I so appreciate. First, that using the social determinants of health framework, it really widens the lens in which you see your data. Second, that adding new and atypical data sets into the algorithm for how you view your community, it changes the narrative, it changes the story, and it changes the picture for how you are framing the community that you see. Third, in our experience, quantitative data is huge, but naturally has its limitations because it requires people to gather it and make it available. And I think most importantly for us was the realization that community members, youth, partners, the extent to which they are engaged and invested in being present in your work greatly influences your capacity to be successful, both in filling the information gaps that the data cannot fill, but also knowing that equity is both a process and a destination. It's important that you do the work and that the work gets done, but it's also important to think about how the work is getting done and who's doing the work. So with that, I just want to say thanks again for this opportunity, June, and everyone at CHCS. I'm going to turn it back over.
Thanks, Parrish. We're going to now turn it over to you, Bill, to tell us about your work with United Way.
Well, thank you very much for inviting me to join you on this. And Parrish, great stuff. Thank you very much for that. I hope that what I have to contribute is helpful, if only as confirmation of what most of you already know. I'm going to cover what you'd expect, I think, what we did and why, some of the challenges, et cetera, and I'll describe the collaboration we are pursuing, if I can make this work. As background, many of you already be aware that United Way is the largest provider of human services in the country, besides the U.S. government, and therefore local social service agencies are very much partners in the effort to fight the effects of poverty. Each local United Way focuses on local community problems or issues with the help of volunteers, and it's really the energy, skills, and passion of local people who want to improve local conditions that defines what the United Way does. Initiatives fall under the broad headings of education, health, and financial stability, and can focus on anything from meeting basic needs and accessing services to more complex challenges. But as we all know, nothing is simple, and simply funding programs in isolation is unlikely to create long-lasting change. Impact requires an integrated approach that sometimes takes us outside of our comfort zones, and measurement approaches need to migrate along with that. And I'd refer you to Mark Kramer and John Kenya's work at Stanford Social Innovators regarding collective impact on that. So sustainable system change, which I suppose is our holy grail, forces us to think broadly about what we want to do and to assemble partners who can address barriers to change. Behavior change, like adopting regular toothbrushing, is more challenging when a family is worried about losing their home, an example of the need to address social determinants of health. So this integrated approach to achieving impact may be a shift for many local United Ways and requires development of new muscles, and as I said before, treading in new territory and working with new partners in some cases. In Central Jersey, there is a large low-income immigrant population and low oral health awareness and utilization. So in the case of this oral health collaboration, we wanted to adopt the promising practices of community healthcare workers, or promotores, in order to both promote adoption of preventive practices as well as to improve care coordination between dental practitioners and pediatricians. But doing that requires partners with resources both in the community of healthcare consumers as well as the community of providers. So we have a core group consisting of the American Academy of Pediatrics in New Jersey, the local Head Start, and United Way of Central Jersey. And we have our lofty goals, as you can see. And what we really want to discover is what happens when we try this. because we know it will evolve and change and hopefully improve over time. The school has a well-developed system of parent engagement and a continuously changing population, so that presents an interesting opportunity for continuous improvement. And the American Academy of Pediatrics has a well-developed network of practitioners. So we want to see if we can recruit a group of parents to act as oral health care coordinators to promote preventive care, increase utilization and compliance. As new children and parents enter the system, they benefit from knowledge transfer from parents currently in the system. I call it a virtuous cycle. It's not actually a new idea, of course. Parent groups train new parents to become part of a group in many different settings, like a parent-teacher association. So this is a light-handed approach down a well-worn path. But we also want local practitioners who would benefit from improved oral health care practice among this community of families and increased revenue to provide incentives for the care coordinators. And we've also talked to the local hospital about measuring cost savings. So things change, and I think that's usually a good thing. I think we risk a short-lived effort if we don't find a way to continuously recruit new partners and energetic support, and that will certainly be part of this effort as we recruit social services agencies to be part of it. And along with that can come adoption of new goals. In all collaborations I've been involved with, there's been an intention to bring evidence-based strategies to work in our local situation with adaptations for the local situation. And that's true as we look at the way promotores work around the country. And new partners, of course, can mean new sources of funding. So this is probably pretty obvious, but failure can lead to new skills. I remember a town hall meeting that included the whole town council, the entire school district administration, all the school principals, lots of teachers and parents, in order to launch a community-wide school-based collaboration. And there was lots of enthusiasm from the people I had as partners, but there was one person missing, the mayor, and he wasn't part of it, so it wasn't going to happen. So I learned that some stakeholders need to buy in even if they aren't partners in the collaboration. As this oral health collaboration continues, new partners will join, particularly among providers, and that's what we will need to create a sustainable change. And I think we will develop skills and innovation that lead to the next iteration and hopefully better results. So the CHCS webinar series that we've just completed helped in lots of ways, including identifying challenges beyond what we might have originally targeted. Reminders that the focal population needs to be involved at the start, and how, while we might be interested in oral health, we won't succeed unless we understand the context. And I think that identifying the people who will benefit as potential funders increases the chances of sustainability. We can't rely on national grant-making institutions for the long term. I'd also say that participating in the webinars did increase the commitment of the collaboration partners. At one point, we were on a conference call to realize that we had reached agreement on the goals and were ready to start planning an implementation approach, and that had a lot to do with what we've been covering in the webinar. So it just remains to express thanks to CHCS for their effort and high standards as we embark on this journey to address social determinants of oral health in Central Jersey. And please contact me if you want to discuss any of this. Thanks.
Thanks, Bill. So at this time, we have a few minutes to take some questions that have been submitted. I'd just like to encourage everyone to please use the Q&A feature to send us any questions you have for me, Parrish, or Bill. The instructions are up on the slide right now. So our first question came through following Parrish's presentation, but I think it probably applies to you as well, Bill. It's around health literacy capital and some ideas, just asking for our ideas for conducting a statewide oral health literacy assessment. Any thoughts there?
Somebody else to pay for it.
I think it's a great question. I know that particularly with young people in the past couple of years, there have been folks with, I'm not going to remember the full name, but they had the School Health Information Project. They designed a health literacy tool to be used primarily with school-based health centers, and they were piloting and working on replicating in states around the country. And so I would say in North Carolina, I've definitely had some thoughts about looking into that tool to see how it could have expanded capacity within the context of oral health. I find often, though, that conversations around oral health literacy and particularly like context of building oral health literacy, in my experience, oftentimes doesn't fully encompass kind of some of the cultural disconnects between the system of care and people in the community. And so I would say that I would love to see both an assessment and a tool designed through kind of a grassroots process of making sure that the people who have the most stake in it have the pens and papers and are doing the building themselves.
So if you want to send me your contact information, I can get back to you on some ideas. One is not to use literacy in this way, because it can mean so many things to so many people.
Thanks, Bill and Parrish. Yeah, I just also wanted to chime in to say that it can be tricky, particularly to track literacy. It's a hard question to ask, and it's hard data to collect. I know that some hospitals and providers are collecting it on behalf of CMS through the CAHPS surveys, the Consumer Assessment for Hospital and Provider Services. But even then, it's difficult for someone to answer truthfully and how to ask in a non-biased way if you understood what the provider is saying, if you understand the value of a given service. So yeah, I think there's definitely some movement needed in terms of how to get at the root of asking people in the right way, so that way they can give an answer that's meaningful. So I just want to also pose another question that's come through. Sorry, reading and talking at the same time. We got a question for you, Bill, about engaging the community. Specifically, any thoughts about how you're planning to recruit parents to be coordinators and how you might keep them engaged?
Well, I'm lucky because I'm got the benefit of a partner with a very well-developed parent engagement approach. So they are used to taking on social issues, and our hope is that while many of them won't need the services, they certainly will recognize the benefits of improved preventive care, and as a result be willing to share that knowledge. There's nothing new about this. People actually don't mind helping other people. That having been said, incentives are very much part of the discussion, and if we can succeed in having providers who benefit, whether from lower costs or increases in revenue, if we can convince them to provide incentives, that may certainly be part of our approach.
Cool. Thanks, Bill. Just quickly want to answer a question about additional resources. That's actually on the next slide. We'll talk through a few once we finish the Q&A. There was also a follow-up about oral health literacy assessments and how that could potentially be part of a statewide oral health survey. So any thoughts about or suggestions about how to incorporate the two? Parish or Bill, it's open. It's not posed for a particular person.
Hey, the only thing I would say is that as with the other data that is being collected and synthesized, it's going to have its limitations. So I would, but also has this kind of double-edged sword of being an important part. And so I would spend some time thinking through what exact information are you looking to gather to determine whether a statewide survey is the best process, and proactively kind of build a plan for how you might fill the gaps of what you cannot hit on with the survey, because creating and disseminating a survey and getting information back assumes that that survey is going to connect with a particular population or a particular person in the place where they can, and in the frame and format that they can access. So I would say any type of survey, well, I would figure out what you need, figure out if the survey is the best conduit for getting what you need, and if so, how can you think through alternative ways of gathering data that helps round out the picture of what you're trying to see.
Good answer, Parrish. Thanks.
Yes, thank you both. We have another question for Bill or Parrish. How did you engage members of your target community in your planning process?
This is Bill. Our Head Start partner has access to parents and has a continuing almost case management relationship with those in need. So we have a very sensitive barometer available to us, and that input has been indispensable.
I think there's probably a lot that goes into answering this question. I think one fundamental part is recognizing who is kind of the champion or the backbone and who's going to carry kind of the message forward and not necessarily be the face of what is happening, but be the person who's going to coordinate the message that is being collaboratively put together and who's going to have boots on the street and talking with people. I think it's good to have kind of that foundation so that people know where to go and there is an established backbone for reaching out and making that connection.
Thanks, Parrish. So another question is sort of a follow-up to that in terms of engaging folks who you haven't been able to contact. Any thoughts there on reaching communities that you know are critical to moving the needle on the disparities, but perhaps don't have a partner?
I think this is a question about how to engage new partners. The one approach that we were looking at was to include faith-based communities. I hope the questioner thinks that's an example. And I think once you've got a track record and you've got something up and running, you can be more convincing with those who are in separate populations, separate communities, and to see whether or not they want to participate. I think that may be an obvious answer. I don't know if that was getting to the question.
Hey, what I would add is coming more from kind of the community organizing framework is that I think that you should set your intentions when you start to talk about community engagement less as a component of a project and more as an intersectional strategy of your organization that is ultimately going to strengthen the capacity of your organization or your coalition. And in doing so, recognizing that community engagement in many ways is playing the long game because you are building trust and building relationships with communities. And I'm assuming that kind of we're talking about disconnected, disengaged people who we're trying to connect with. And so these are people who do not have historic relationships that are necessarily tied to the structures or the organizations in the community. And so I think expect to invest time in relationship building and recognizing that, you know, within the context of equity that to be connecting with these the harder to reach populations, if that's what we're talking about, then expect that you need to invest more heavily in their capacity to participate than those who don't have the same degree of structural barriers. And in doing so, you need to prepare for how holistically you can, as an organization or a group of people, build that connection over time so that relationships are fostered and grow so that they build gateways to those harder to reach people.
Great. Thank you both for that. We've only got about 5 minutes left, so I think we are going to conclude the questions and answers section. I just want to quickly say that this, again, is being recorded, so if anyone would like to reference the questions and answers section, you'll have an opportunity to do so through the recording. So in finishing up, for those interested in learning more about community partnerships and social determinants of oral health, here's a list of resources, starting with the CDC framework that I referenced on the slides around 6 effective interventions. So this particular resource lays out the framework for addressing social determinants in the community and also provides a number of case examples. It's not specific to oral health, but as you have likely noticed from this presentation, we have not made a distinction between the two, just with the understanding that oral health and physical health are not separate from one another. So a lot of the suggestions and guidance in this resource are helpful. Also is a reference for collective impact. Thank you, Bill, for referencing Kenya's work. This is actually a follow-up. It's called the Equity Imperative and Collective Impact and describes how collective impact can be used to advance equity. And then a third reference is on social determinants of oral health is a research piece on implications for action in which it elaborates on the 6 effective approaches that we talked about in this presentation to talk about what's most effective in the oral health space. So just want to say thank you to everyone again for joining us. I want to give a big thank you to our guest speakers, Parrish and Bill, all attendees for joining today, and last but certainly not least, the DentaQuest Foundation. And just want to repeat for everyone still on the line that the slides and the recording will be available on our website at chcs.org. You can feel free to download those and reference them at your leisure. So with that, we will adjourn. Thank you, everyone.
Once again, that does conclude today's conference. We thank you for your participation. You may now disconnect.